everybody. At the outset, let me thank the organizers for giving me this opportunity to discuss cardiovascular disease as a comorbidity in people living with HIV. So this is the outline of my presentation. We will briefly discuss the current evidence on severe risk in people living with HIV, discuss some of the prevention strategies, and finally look at some of the management strategies for managing this disease in people living with HIV. Well, now we know that thanks to antiretroviral treatment, people with HIV are having near normal life expectancy, and this is data from the US, which suggests about 6.9 years less overall life expectancy and about 9.5 years lower comorbidity-free HIV over calendar years of initiation of antiretroviral treatment. So comorbidity burden is quite significant in the HIV-infected population, particularly happening at a younger age at higher rates. And in the same study, different comorbidities were assessed, and this is data on cardiovascular events. And as you can see here, the comorbidity burden expected time remaining at the age 21 years without a CVD event is lower in HIV infected individuals as compared to HIV negative population, though this gap is narrowing over the last few years. When we talk about CVD events, we are looking at multiple clinical outcome events. We are looking at acute myocardial infarction, coronary artery disease. We're talking about ischemic stroke. We're talking about heart failure, both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. We are looking at pulmonary hypertension, which also significantly has been reported prior to the ART era in HIV-infected individuals. And finally, arterial and venous thrombosis and peripheral artery disease can happen at a higher frequency amongst people living with HIV as compared to HIV-negative population. If you look at the global burden of atherosclerotic cardiovascular disease, and this is a heat map showing you population attributable fraction in the last 26 years, population attributable fraction of cardiovascular disease in HIV-infected individuals has increased from 0.37 to 0.97, and so has Delhi increased over the last 26 years. As you can see here, this heat map shows you differential prevalences of these two outcome measures across the world. So it's not a universal homogeneous phenomena. Based on different geographies, you have different kinds of prevalences of cardiovascular disease, atherosclerotic, amongst people living with HIV as compared to the overall population. Pooled risk estimates of CVD risk in HIV-infected individuals has been demonstrated to be higher, almost to the tune of 2 to 2.5 times, even if you look at the overall cardiovascular events, as well as myocardial infarction and stroke. So HIV-infected individuals have a higher risk of having CV events as compared to HIV-negative population to the tune of 1.5 to 2.5 times that which is seen in HIV-negative population. So it's a significant problem that needs to be tackled. If you look at incidence risk of acute myocardial infarction, for instance, amongst HIV-infected individuals as compared to other traditional risk factors adjusted for smoking, age, etc., you can see that in HIV-infected individuals, the risk of myocardial infarction is 2 times as compared to the HIV-negative population. And if you compare it with the traditional risk factors like hypertension, diabetes, dyslipidemia, and smoking, which was in the InterHeart study, it's almost closer to these traditional risk factors. So there's often a understanding that perhaps HIV should be considered as an independent risk factor in assessment of severe risk amongst population. If you look at the prevalence and survival free figures for heart failure by HIV serostatus, as you can see here, HIV infected individuals have a higher prevalence of heart failure, both preserved as well as reduced ejection fraction as compared to HIV negative population. Most of this is not surprising because since CV events, myocardial infarction rates are higher in HIV infected individuals, it's quite rational to assume that heart failure would be higher. But not all heart failures are explained by higher incidence of acute myocardial infarction. So there is an independent effect of HIV on development of heart failure, and studies have shown its link to advanced HIV status, particularly when the CD4 is less than 200 or the viral load is not undetectable. Finally, sudden cardiac death has also been reported amongst people living with HIV. And in this study here, as compared to HIV negative population, those with a low CD4 count, less than 200, have a higher incidence of sudden cardiac death. And those who don't have an undetectable viral load also seem to have a higher incidence of sudden cardiac death. So more likely HIV related factors are associated with sudden cardiac death in terms of not being immunocompromised as well as not being virologically suppressed. So if you look at the issue of cardiovascular disease amongst HIV infected individuals, it's a complex issue. And we have three important perhaps contributors to this higher risk of cardiovascular disease. Obviously, lifestyle risk factors which are present in the general population seem to be having a little higher prevalence in the HIV infected population. Then we have the effect of combined antiretroviral treatment. And finally, in spite of effective antiretroviral treatment as well as viral suppression, you have residual persistent immune activation, which is present in HIV infected individuals. All of these three can contribute to development of obesity, metabolic syndrome, hypercoagulable state, pro-inflammatory milieu, endothelial dysfunction, platelet dysfunction, and persistent immune activation has also been associated with development of myocardial fibrosis, which can be very important factor in development of heart failure. And then lifestyle risk factors as well as combined antiretroviral therapy can also lead to metabolic dysfunction. We'll discuss some of those issues. All of these things can lead to development of cardiovascular disease. In terms of lifestyle risk factors, we know that perhaps people living with HIV have a higher risk of higher prevalence of having high uh, risk factors in terms of CVD events. But again, if you look at the heat map globally, this varies according to the geographic regions. And mostly this is, for example, in sub-Saharan Africa, you'll have high rates of blood pressure, raised blood pressure in a young population, but lower rates of blood cholesterol, as well as higher rates of fasting blood glucose and lower rates of tobacco smoking. So again, the lifestyle risk factors contributing to atherosclerotic cardiovascular disease in people living with HIV varies by geographic situations, and interventions need to be designed very specifically according to the regions, assuming the prevalence is associated with these different risk factors. The other issue is combined antiretroviral treatment, and we knew since the beginning of the event of highly active antiretroviral therapy that combined antiretroviral therapy is associated with lipid dysfunction. But we just focus on some of the contemporary ART, and we all are aware about the issue of significant weight gain with dolutegravir. And this is a network meta-analysis which shows you higher risk of weight gain in patients who are on dolutegravir-based regimen as compared to, say, efavirenz 600 or efavirenz 400. When you compare dolutegravir with a mixed backbone, comparing it with TAF, with dolutegravir. In that instance, the weight gain is less without TAF when you combine it with dolutegravir, suggesting that TAF adds to the weight gain associated with dolutegravir. So in the same network meta-analysis, very clearly shown that weight gain is significantly more when you use TAF as compared to TDF, or when you use TAF as compared to abacavir, and when you use TAF compared with AZT. So in the contemporary ART situation, we are looking at integrase inhibitors as well as TAF being associated with significant weight gain. And now, what are the metabolic consequences of this is something we will discuss. As we know, in the public health scenario currently in the world, there is a transitioning to TLD or dolutegravir with TDF-based regimen happening across the world, and this is one of the large study from Africa, which looks at what is the risk of having increased BMI in individuals who transition to TLD based regimen. And as you see here, after transitioning to a TLD based regimen, there is an increase in BMI, more starkly seen in the female population as compared to the male population, as well as in elderly populations. And then, of course, when you switch from efavirenz, you would tend to have a higher weight gain happening with dolutegravir initiation or transitioning. And this is perhaps because of an understanding that efavirenz may actually lead to weight not gaining weight, and it is also mediated through polymorphisms in the metabolic pathways of cytochrome enzymes 2b6 in efavirenz. And if you look at the waist hip ratio impact as well, you can see here again, after transitioning to TLD, there is an increase in the waist hip ratio. What are the consequences of this in terms of development of metabolic syndrome is something, some evidence is emerging on that. Also, when we talk about dyslipidemia, this is the incidence rate ratios in the respond study, which looks at the adjusted incident rate ratio for all people living with HIV, ART experienced and ART naive. And you can see here, as compared to PIs, uh, the uh, dyslipidemia is less with the integrase inhibitors, but not when you compare it with the NNRTIs. So when you're transitioning from NNRTIs to dolutegravir, then you may see a higher incidence of dyslipidemia happening in the population. As far as TAF versus TDF in terms of dyslipidemia is concerned, TAF is associated with higher rates of dyslipidemia, but it is also associated with higher ratio of total cholesterol to HDL, and that is something which may not really impact the cardiovascular risk. But there is large amount of data now to suggest that when people switch from TDF to TAF, there is a significant increase in LDL which happens, as well as triglycerides, and this is clinically significant increase in terms of the number of people needing, proportion of the people needing lipid lowering treatment, as in the OPERA cohort, which increased when individuals switched from TDF to TAF. So all of this can come together, and when you really look at the prevalence of metabolic syndrome, which uses some of these parameters in defining metabolic syndrome as a risk calculator, you see there is a statistically significant risk of having a metabolic syndrome in individuals who are initiated on a TAF FTC DTG based regimen as compared to individuals on TDF FTC DTG or TDF FTC efavirenz. So it seems that TAF FTC DTG seems to have a higher incidence of metabolic syndrome when initiated, at least in ART naive individuals. When you use these parameters to estimate CV risk across various calculators, and this is data from the advanced trial at week 96 using 3 different CV risk calculation scores, there is a significant increase in cardiovascular risk, which happens at week 96, when you calculate the Q risk, when you calculate the CV risk by the Q risk tool, uh, in the TAF FTC DTG group as compared to DDF FTC F average. So maybe it also translates into excess CV risk, which can happen with a regimen like TAF FTC and DTG. But this is a very interesting study. Of course, this is an observational study and is subject to confounding biases and particularly channeling biases. But what this showed predominantly in the European population, that the incidence of CV composite events after initiating an INSTI-based regimen was 2 times at the end of 6 months, and it continued to be higher up to 24 months, though at lower incidence ratio, as and then subsequently settled down. So this is the first signal of real world data in the European population suggesting that there may be a higher risk of composite CV outcomes, which was defined as myocardial infarction, stroke, and interventions needed for managing acute myocardial infarction. And this can happen very earlier on after starting an integrase based regimen, particularly at 6 months, and maybe going up to 2 years, albeit at a lower rate. Of course, more studies are needed to confirm this, but this is something which is emerging and an interesting aspect to look forward to and monitor for with future studies. The last aspect is, of course, persistent immune activation. And as we know, immune activation uh, is associated with viremia, microbial translocation because of destruction of the gut-associated lymphoid tissue, and co-infections, particularly CMV and hepatitis C virus infection, that can lead to persistent immune activation, which causes T cell activation as well as monocyte macrophage activation, leading to release of pro-inflammatory and pro-fibrotic cytokines, and this leads to further hypercoagulation, endothelial dysfunction, and myocardial fibrosis. This can lead to cardiovascular events. So these are the three important aspects of cardiovascular disease events happening because of lifestyle factors, antiretroviral treatment, and immune activation. Now, after understanding this, let us look at whether we can have some prevention strategies and what is the evidence there amongst people living with HIV. So as clinicians, it's very important for us to be very vigilant to screen for CV risk at baseline as well as at subsequent follow-up at least yearly amongst people with HIV on antiretroviral treatment. So apart from measuring lipid levels and looking for diabetes, looking for lifestyle factors like smoking, diet, level of exercise activity, waist circumference measurements, and finally having a BMI, or all of these things should be on record and should be used to mitigate the excessive risk in people living with HIV. Once we have these parameters, it's important to estimate CV risk, and we know we have different risk calculators available for estimating CV risk in the HIV negative population, but the performance discrimination and calibration in the HIV positive situation has not been really great. As is shown in this study using the Framingham equation or the ACC-AHA equation, across all categories of CV risk, it looks like traditional scoring systems that are used in HIV negative population tend to underestimate CV events in HIV infected population. And that reason may be because of the multifactorial aspect, the immune activation aspect perhaps contributing to that excess risk, which is not accounted for in any of these CV risk tools. So there are some specific HIV risk tools. So now we have this DAD risk score, which is predominantly in the European population, and it really performs well in the European population, but has a very modest performance in the US population. But what it essentially, this study shows that the DAD, FRS, the Framingham, and the PCE All of these seem to perform reasonably well in the HIV-infected individuals. And the dad uses additional HIV-specific aspects or HIV-specific measures like CD4 count, recent use of abacavir, protease inhibitors, etc., to estimate the CV risk. So when we in clinical practice screen for severe risk, we may use any of these tools, and we'll see later on how to enhance that for HIV related factors. So to improve on that CV risk, can we look at some other markers? And this is coronary artery calcium score prevalence in HIV positive individuals and HIV negative. As you see here, the prevalence is quite similar in these two groups, although in the HIV positive population, it is more in individuals at younger age, as well as in individuals who have lower prevalence of traditional risk factors. So the CAC score of more than 0 tend to happen in younger people living with HIV as compared to the HIV negative population. And in terms of the types of plaques which you see in the people living with HIV, you see as compared to HIV negative, it's more of non-calcified plaque which is seen as compared to calcified plaque, which is seen more in the HIV negative population. The consequences of non-calcified plaque are threefold. First is they can't be really picked up on a routine CAC. We need to do a CT angiography to assess that and then decide whether that would perhaps add to the severe risk in terms of developing aggressive risk reduction strategies in these individuals. The second aspect is that the non-calcified plaques are more amenable to rupture, so you have more event rates happening with non-calcified plaque. And finally, the statins tend to be more effective if you have non-calcified plaque as compared to calcified plaque. So these are the important clinical consequences of differentiating between a calcified and a non-calcified plaque. There are various publications looking at trying to incorporate a CAC score along with the ASCVD score traditional, which is used in HIV negative population, but this is something which is still area of interest and emerging. So when you approach CV risk in HIV infected individual, you have to assess ASCVD risk and then look for ASCVD risk enhancers which are HIV specific. So we are looking at viremia, we are looking at delay in ART initiation, we are looking at lower CD4 counts, treatment failure with antiretroviral treatment, metabolic syndrome, fatty liver, lipodystrophy, and hepatitis co-infection. If you have any of these factors, you upgrade or enhance the risk of ASCVD score that has been calculated by the traditional risk calculators by a fraction of 1.5 to 2 times. And then the final score can be calculated to design an intervention. In individuals, of course, as in HIV negative population, having a clinical ASCVD or an LDL more than 190 or a diabetes, you have a high risk approach of lifestyle optimization and initiation of lipid lowering treatment. In individuals with more than 7.5% severe risk over a period of 10 years, you follow an high risk approach. In individuals less than 7.5%, you have a low moderate risk where you focus on lifestyle optimization and yearly reassessment. In terms of lifestyle optimization, there is some evidence from randomized control trials to look at dietary intervention, physical activity, etc., specifically in the HIV infected population. This is one such trial where ART naive individuals were randomized to dietary intervention versus no dietary intervention. And as you can see here, for individuals who initiated ART with a dietary intervention, the BMI tended to remain stable. The total cholesterol declined, the LDL cholesterol declined, and the triglycerides declined, suggesting that dietary intervention at initiation of antiretroviral treatment may be an important component which can try to prevent ART-associated dyslipidemia. The other aspect is, of course, lifestyle intervention, including physical activity. And again, this is a randomized control where there was an intense intervention group which looked at intervening in terms of diet as well as physical activity, and measuring physical activity by a hand worn accelerometer, etc. And you can see here the aggressive intervention group had a greater decline in weight as well as BMI, both at 3 months versus 6 months and 6 months as compared to the control group. So when we talk about lifestyle modifications, we need to be really very focused in terms of develop programs which incorporate these issues and are sustained over a period of time to mitigate the higher severe risk in HIV infected individuals. Interestingly, smoking cessation has also been studied in people living with HIV, but just focusing on smoking cessation by giving nicotine replacement therapy is something which may not really work in the HIV context. So this is again a randomized trial where there was an integrated intervention which not only looked at smoking abstinence, but also working on anxiety and depression by cognitive behavioral therapy. And as you see here in this quit arm, which has an integrated arm, there are higher abstinence rates and which are sustained over a period of 6 months follow-up, and also improvement in the mental health scoring systems, both for anxiety as well as depression. So when we are talking about using smoking prevention strategies, perhaps we need to integrate that into mental health related interventions amongst people living with HIV. When we talk about drugs for treatment of dyslipidemia and HIV, statins are of course drugs which are used in the context more commonly, and there is now enough evidence to suggest that statins work fine in terms of reducing LDL cholesterol and then subsequently reducing cardiovascular risk in HIV infected individual, as this meta-analysis shows here. Statins have pleiotropic effect, and not all statins are equal. And this is a randomized trial amongst people living with HIV, looking at the pleiotropic effects of pitavastatin versus pravastatin, where it demonstrated a significant decline in inflammatory markers like soluble CD4, CD14, and also reduction in oxidized LDL, as well as percentage change in lipoprotein fractions of cholesterols. So not all statins are made equal. So it seems that pitavastatin, rosuvastatin, and to some extent atorvastatin are some statins which have better effect in terms of pleiotropic effects as well as lipid lowering capabilities. And statin seems to be also safe in individuals infected with HIV on antiretroviral treatment. And this is a meta-analysis suggesting it is as safe as compared to control population. And if you look at multiple adverse events like myalgias, elevation in CPK levels, incidence of diabetes, for example, some statins are associated with development of higher risk of development of diabetes. So it seems this is true also in the HIV infected population, though the rates are not higher as far as adverse events of statins are concerned as compared to the HIV negative population. One of the important aspects, of course, is the drug-drug interactions with statins. And right now we have drugs like dolutegravir or integrase inhibitors, which tend to have no interaction expected with any of the statins. But we have to be very when we use protease inhibitors, as some interaction is expected with this. So in terms of interactions, pitavastatin seems to be a statin which is not associated with significant drug interactions along with the contemporary ART. To test the effect of statins, we have this REPRIVE trial which is ongoing, where asymptomatic people with HIV on ART with a higher, with a 10-year ASCVD risk score of less than 15% randomized to placebo and pitavastatin, and looking at hard cardiac endpoints CV death, MI, unstable angina, TI, stroke, revascularization, and PAD. So we would expect some results coming from this trial soon, and this would help us in terms of trying to minimize severe risk if this trial shows benefit in terms of hard clinical endpoints of MACE in people living with HIV. People have looked at aspirin, and this is a randomized trial looking at 300 versus 100 milligrams of aspirin versus placebo, and both in terms of platelet effect measured as thromboxane A2, as well as inflammatory markers there was and flow mediated dilatation. There was no difference with the use of aspirin, so this is quite disappointing result in terms of using aspirin amongst people living with HIV. But as we know, in the HIV negative population, there has been a moderation on the recommendations of using aspirin for preventing severe events in HIV infected non-HIV infected individuals because of the persistent higher risk of bleeding which may happen with the use of aspirin. Finally, in terms of ART risk, some of the ART associated with dyslipidemia or increased CV risk, can we mitigate that by switching back? So these are two studies which are looking at switching from TAF to TDF. This is the characterized study, which is an open label extension of the advanced trial, where individuals on TAF were subsequently offered open label TDF DTG. And as you can see here, there has been some significant improvements in terms of weight, as well as improvement in lipid profile. Though the numbers are really small, suggests that there may be some reversibility associated with the weight gain when you switch back from TAF to TDF, as well as improvement in the lipid parameters. Though more data is needed before we conclude on. This is another study also which switched from TAF to back to TDF, showing a decline in the cholesterol markers, whether it is total cholesterol, LDL, etc. And in this study, they demonstrated a decline in the ASCVD risk score from 6.3% to 6% in people who switched from TAF to TDF. But in the control group who did not switch, there was an increase from 8.4% to 9.5% and 9.1% at 2-year follow-up. So this is something which we need to keep an eye on in future in terms of trying to look at whether switching back to so-called lipid-friendly ART would improve cardiovascular outcomes. And in the NEAT 022 study, which looked at switching from boosted protease inhibitor to dolutegravir in high-risk individuals with a ATP3 score of more than 10%, improved lipids. And in there were two arms where dolutegravir was immediately switched to, or dolutegravir was switched in a delayed fashion. And in the individuals who had switching immediately, you see a decline in the people needing lipid lowering treatment as compared to people who switched later. So moving away from boosted protease inhibitors to integrase inhibitors, moving away from TAF to TDF may be something for which, of course, more data is needed before this can be implemented in routine clinical practice. Finally, we had that third arm of immune activation, and that has been an area of intense interest in trying to develop interventions to reduce immune activation, and then subsequently having impact on increased cardiovascular risk. So multiple therapies have been studied with different mechanisms of action, mostly targeting gut microbiome. Unfortunately, there have been mixed results in terms of surrogate endpoints of immune inflammation or inflammatory markers, and we don't have much data on hard clinical endpoints of use of this. So this is again something which needs to be refined, and needs to be more studies need to be done to look at whether we can develop some interventions to reduce immune activation, to reduce ASCVD risk. Finally, let us complete by looking at some of the management strategies. Overall, in the HIV-infected individuals, management of cardiovascular events in terms of protocols are similar to HIV-negative population. So for thrombolysis, interventions, mechanical thrombectomy for strokes, etc. All of those guidelines which are used in HIV negative population, the same management strategies are currently recommended for people living with HIV as well. The only issue is whether you have a higher risk of adverse events associated with these interventions when we manage people living with HIV as compared to HIV negative population. And so for specifically one aspect that we are looking at is PCI, and there is some data to suggest that in the HIV infected population, the risk of mortality, the risk of sudden cardiac death, the risk of recurrent myocardial infarction, as well as the risk of target lesion needing revascularization or even MACE events are not higher after a post PCI intervention as compared to the HIV negative population. So that is quite reassuring to suggest that these interventions can be offered to our patients without any increased incidence of adverse events. Of course, there are other aspects, particularly drug-drug interactions with some of the platelet drugs, uh, drugs which are used in DAPT, like dipyridamole, prasugrel, etc., which predominantly interact with the protease inhibitors. So we need to look for those interactions and optimize the antiplatelet agents in this context along according to the ART regimen that the patient is using. In terms of CABG, this is a study from Vienna in Austria, which is one of the largest studies with contemporary ART of CABG, and that is just 17 patients. But here they look at very long follow-up of almost up to 8 years. And it seems that the outcomes of CABG in people living with HIV are similar to the HIV negative population. So the real carry home message is that the interventions that we use for managing CVD events in HIV positive in HIV negative population can be applied safely and effectively in the HIV positive population as well. So in summary, awareness about this excess CV risk is very, very important. We need to be vigilant in our clinical practice, periodically follow the patients up with all the parameters which are associated with increased CV risk. And it is very, very crucial to monitor and intervene at the right time to prevent these events from happening in our patient population. The ASCVD risk prediction tools currently, as I've already showed you, underperform in the HIV positive context. So in that aspect, we need a lot of research to look at novel markers which can improve the calibration and discrimination of CV risk assessment tools. Whether we can incorporate them in the traditional CV risk assessment tools to improve prediction so that aggressive intervention can be offered to these individuals to reduce CVD events. Of course, weight gain is something which is an emerging area of interest. The consequences of that in terms of metabolic syndrome, the consequences of that in terms of cardiac events, high risk of increased cardiac events or other comorbidities like diabetes is something which is of intense interest and needs to be studied in the current era of contemporary ART. And finally, I think at the public health perspective, perhaps it's important to perhaps start thinking about integrating HIV and cardiovascular disease care models. And this is something which has already started in Africa, and that research priority should be to try to look at implementation research of trying to scale up and integrate HIV and CV disease care models. So I thank you and would be happy to take any questions.